Right, hi everyone. So just to introduce ourselves, start off, thanks for gathering around the tables there. You should all have flip chart paper and a couple of handouts on the tables. So the three of us will be facilitating the workshop today. So I'm Abby, I'm the Patient and Carer Involvement Coordinator with the network.
Okay. Hello everybody, I'm Sushmita. I'm a consultant therapist in stroke and I work in North Wales. So I've come all the way from North Wales to share our work actually with an example of PPI work that we have done there. And we can see that it's very popular workshop, so we'll try to keep to your expectation actually.
Hello, I'm Becky. I'm a speech and language therapist and I've been involved in the project that we're going to briefly discuss today.
Yeah, so just to start off with then, these will be the timings for the day. So yeah, I'm going to start off just running through a little bit about what PPI is. Hopefully won't take too long on this, just a little run through just to make sure we're on the same page with it and we're going into our discussions later with a good understanding. And then Sushmita and Becky will come back up and talk through about their project, and then we'll be spending the rest of today talking on our tables and hopefully having some really good discussions there. And we'll just come back together at the end to feedback from what we've been talking about on our tables and see if there's any group learnings there that we can share. Okay. Left my notes on the table, I'm back now. So thinking about what PPI is then, so patient involvement, it's referred to as a lot of different things. These words on the screen there, you might hear PPI, so patient public involvement, PCI, patient carer involvement, co-production, co-design, so they're types of involvement, but essentially all these words are used across research literature. They're all kind of referring to the same thing a lot of the time. Just to ask the room a little bit, does anybody, you can shout out, put your hand up, does anybody want to tell me a little bit about what PPI is? So first of all, who are we talking about when we're talking about PPI? Patients and public, yep, given away with the PPI. Yep. Yeah. So patient, public, carer, yeah. There's a lot of different things that it gets referred to. We're all talking about the same thing today. So what about kind of family members? Would they be included in who we're talking about here? Yeah, lots of nods. Somebody who might work in a charity, speaks to these people every day, has a good insight, would they be? We've got some nods here. Somebody who works in a charity, we're not talking about them when we talk about patient, public, or patient and carer involvement. We're talking about those people who have the 24/7 experience, who have those conditions, who have been through the services themselves. So if we work in an area or with a condition, that brings different expertise to the table, but what we're talking about today is involving those people who have that lived experience. So that's who. Anything else, kind of, what is it? What do we mean? We're involving them, but perhaps how? How is the next question then? So how would we involve them, or how could we involve them? Yeah, so focus group, what community need is, yeah, that's ways. Yeah, there's a lot of different ways that we could involve people. Our patient and carer group that was up before, that's one of them, going to a group and asking them for their support. Anything else on that? I will run through these next, so I won't go too much into my own comments at this point. Excellently put. Whatever way is meaningful and works for them is a great way of how. Okay. Why? Yeah, got they've got more knowledge on that lived experience. Yeah, yeah. Somebody else start saying something? Don't make decisions about us without us. Yeah. Good. And finally, about my W's, when might we involve people? From the beginning, yeah, good. So I've sort of mislabeled this slide as well. What we're talking about here is what is good involvement. So it's listening to patients, carers, family members, just those people, not other stroke specialists, just those people with the lived experience. It's letting them inform, shape, really working together to make decisions with people with the lived experience. And it's not tokenistic, it's making sure that it's meaningful. So it's not just having somebody in the room, it's actually letting them have influence over the decisions, and thinking about that power shift on sharing the decision making. And it's everyone's responsibility. It's not just something to leave up to, that sounds like a patient and care involvement coordinator's job, that sounds like a management job. It's everybody's responsibility to be thinking in this way. One way that we often talk about patient and carer involvement is through the involvement ladder. So I'll just talk you through this ladder a little bit more. You have got some copies of these on your table, which will be able to help in your discussions later, and feel free to take these away. It's available online just for you to be having a think about that through your general work as well. But what this ladder means is at the bottom there with educating and coercion, that's about making decisions for people. So that might be, for example, in coercion, I might say to somebody, you know, I've made these service changes, I've made these service developments, just letting you know that I've made them. And that's about as far as it goes. There's no scope for anything they say back to influence the outcome of that. The changes have already happened. With educating, we might go a little bit further and say, you know, we've made these changes because of X, Y, Z. But again, we're not giving them any scope then for, if they say, I don't think that's a good idea, for that to have any influence. In the orange section, we're working together a little bit more. So with informing then, we might say, I've made these changes, could you give me some feedback on that? So we're starting then to involve them in the discussion, which is good, but we've still already made those changes. So in this orange section, we've got a bit more of a limit on how much their influence can be. The consultation process might be a little bit earlier than that. So I'm thinking of making some changes, or I've got these suggestions for changes. What do you think about that? So you're going in with a bit more of a pre-plan, an idea, but you've got that little bit more scope for them to say, have you thought about this, or what about this? I don't like that. You can see there how it's just that little bit earlier, but you've still already gone in with your own ideas. Engagement is where we start to see a little bit more of that power shift. So engagement, you might go to a group of patients and carers and say, I have thinking of making these changes. What would you like to see? What would your suggestions be? And that's when they're starting to get a little bit more involved from the beginning. So can you see how each step up the ladder we go, each step earlier that people are involved can just give them a little bit more of a power? And that brings us to the purple section, so doing with, and this is where we're working truly together. So with co-design, it would be going to patients and carers and saying, we want to make some service changes, will you design them with us? And all of that decision making is done then together. Or with co-production, it could be, you know, the fact that they're already in the conversations, they're the ones who have suggested the co-design. So each step up the ladder, people are getting involved earlier and earlier, and that power dynamic is becoming more and more joint. In co-production, we might see kind of strategic decision-making, policies, all of that kind of thing being done jointly, which can sound a little bit scary when you think, well, you know, they haven't got the same data that we've got, or other kind of barriers, hesitations, but they come with that lived experience, and it's not about giving them all the power, it's about that joint. We each come with different experiences, different expertise, and how can we do the best things together? Okay. Have we got any questions just about that before I move on? We will have time to talk more on tables, but anything that anybody just wants to ask at this stage? Yes?
Would there be another one on the top that's user-led?
Yeah, user-led would come after that. Today we're looking at co-production and co-design, but user-led would be, as is suggested there, where user-led comes in as they've got more power than the professionals. So yeah, absolutely. Is that something that you've got experience with that? Yeah. Good. I'm sure that'd be a really interesting conversation on your table. Okay, so thinking a bit more practically then, how can we work in this way? There's a lot of different ways that we can work with co-design and co-production. These are a few, a couple there actually, things for you to think about during your discussions later. There's no right way, there's no wrong way. Some things might match better for different teams or different projects. It's just about having to think about these things, and I'm sure that the pros and cons of these aren't new to you. They're common in different research, but just having to think about the pros and cons of them in terms of involvement. So a survey, you've got more people. Are you able to delve into those voices and understand all those voices, or is that dampening voices? Interviews is going to present with some of those challenges of that they take a lot longer, that's more out of your time, but you could get a lot richer detail. Have a think about these just in terms of involvement. Yeah. I think we covered this well earlier, but why do we do it is to make sure that in decision making, we're able to prioritise and deliver on service improvements that really matter to the people experiencing those services and make services work better for the people they exist for. Okay, a couple of quick tips. Think of involving people as the norm, not the exception. So it's not something just to think, well, we've covered patient and carer involvement because we've done it in this project, done it in that project. It's about something which should be done at all levels, in all teams, or at least strived for. So it's the norm, not the exception. Make sure you're actually open, you're truly open to acting on the feedback. If you're asking for feedback and for thoughts, for suggestions, but not acting on them, again, a little bit of a waste of time. And this again comes into, it's easier sometimes if we've got them earlier. If we're hearing those voices earlier, then there's more scope for that, rather than being a little bit lower down the ladder where it's quite late, I haven't got time to reproduce this whole patient leaflet now. Earlier gives more scope and means that we can be more open to acting on it. Working together. This was what that purple section's all about, but ways that we can work together well. Set expectations early on. So things like time commitments, how we expect everybody to behave, accessibility needs, all those things. By establishing those early together, it just helps that relationship throughout the patient and carer involvement. Sometimes that's called a terms of reference. And feedback as well. Imagine, this goes both ways, but imagine giving your time to helping a service develop and then not hearing the outcomes of it, not hearing if any of your suggestions worked or got taken on board. And equally the other way as well. So feedback about for the teams, the professionals, yourselves, is that feedback from how have I been? Could I have done anything better? Could I do anything better in the future? Consider the diversity, cultural backgrounds, time since diagnosis. There's a lot of different diversity factors there which will change your experience of a service. So making sure that you've got a good range of voices there. And I've covered this several times. Involve patients and carers as early as possible. Having said all that, it sounds like a lot of rules there, but it doesn't have to be perfect. Just be brave, give it a go. And moving up the ladder is the main thing. So if you think you're at the lower end of the ladder, you don't have to be aiming for perfect. It's just about moving up the ladder. What can you do to take another step? Great. Okay, I will hand over now. Any questions before I do? Oh, great. All right.
Thanks, Abby. I hope that gets you thinking about PPI. So I'm here to present just a case study that we did it. Well, it's not a case study. It's a part of the service development program, actually, we did, but we took it as a case study from North Wales. So I'm proud to share this because it's a very new stroke service there. So as I told you, I'm working as a stroke consultant therapist, and I came here just because there was a new stroke pathway. So there's lots and lots of opportunities there to work there. So I'm going to be brief, but please do ask questions. It's all in the same line as Abby has said, why did we do it? So I'm just going to cover that. I'll introduce the project a little bit, but we need to I'll tell you a little bit about why we did it. I think we have got the answer in the room, why we did it. And then talk a little bit about how we did it, what are the impacts, some of the challenges and lessons learned, and then I'll introduce the PDSA cycle because we are going to do some table activity there. I hope you have visited our poster there, which is out there obviously. So if you want to know more about it, it's there in the poster. But I'm just trying to very briefly focus on how we did it rather than the nitty-gritty of everything else. So why we did it? The first thing, as I said, it's a new stroke pathway. In North Wales, they did not have a stroke rehabilitation unit, no ESD service. There is no community stroke services there. So that means once they're out of the hospital, they're out of the hospital, and that's really, really sad. So we wanted to do as much as we could do to support these people with stroke, actually, while they're in the hospital. Now, when we are talking about people should not be in the hospital and they need to go out in the community and rehabilitation should happen in their own home, we know the challenges, like especially in North Wales, we knew the challenges that if they're out of the hospital, they're not going to get a lot of support. So we need to support that transition. At the same time, we need to provide as much as we could do. And that is not only about the stroke survivor, and we know that there is a huge need of the carers. So that's the second thing that encouraged us to do that, because the carers' needs are very well documented in the evidence, but there is no evidence-based intervention or guidelines that says that you need to do this to support the carers. But the NICE guidelines, the newer NICE guidelines says that you need to do something about it. And it tells you a lot of things that, okay, how you can incorporate that, how do you support the carers, but we do not know. So that's a gray area as well. As I said, it's scarce community resources, and there is no stroke-specific service. We identified that there is a huge need because the carers are really scared when they're getting out of the hospital. I think it's still where there are stroke services, established stroke services, we still have that, the anxiety in the carers that, okay, oh, you're getting discharged, you are going to be signed off now. So this is it, rehabilitation ends here. So just having that faith that, no, this is the start of a journey. So that's kind of things that we identify that it's a huge need, and how do we do that? The biggest challenge that when I went to North Wales, I just thought that there is a big change in culture. There is still a lot of divide between we provide the service and you are the service user kind of thing. And somebody said that it should be user-led. Yes, but we're not there yet because we're still full-time clinicians. We are working in NHS. We need to open our window to provide that kind of service. And this was an opportunity that how can we involve that, because we know that shift in culture is required. So I felt that when I introduced the idea, the staff, the MDT staff itself, they were feeling, all right, yeah, we need to do that, but when, how? We don't have time, we are very, very busy. I was like, okay, it's not an option, we need to do that. As Abby was saying, PPI is not an option, it should be integrated, because we are existing, the NHS is existing because of the service users. If they are not there, they don't need us, we won't have a job. So I was very passionate about it, but it's having the team to get along with me was a big challenge. But we thought that that's the best way. And then obviously I was finding my feet in North Wales, and then we thought that this is the best way to collaborate with other charities like Stroke Association. Like I came from London, and we have loads and loads of stroke charities there. But in North Wales, I realized that it's only Stroke Association. So I was like, okay, we need to just get them on board. So it was very timely when we were thinking about that. So we thought that, okay, it could be a really good collaborative process while we are planning to have a new service. And obviously, in the previous slide, you can see that the team was very new. It's only 1 year that we started the service. So these are the collaborators. Obviously, I was leading, and Becky, who is here as well, she was co-leading, but it was the MDT team that we worked as a collaborator. We had Stroke Association, Wales as a collaborator, and we had a service user representative, David, who was, again, collaborator. From the day one, he was involved. So when we came up with the idea, we just said, okay, we're thinking of that, how can we work together? And they were all excited, okay, no, we need to work on that. And it's a priority for Stroke Association Wales as well, and it's a priority for service users. So that's where we kind of started. So it started over a chat, actually, just saying that, okay, we're thinking about it, how do we do that? So we just came up with an idea. So I said, okay, why don't I jot down a few things, how we are going to do it, and I'll send it to you, and you just see whether this method is going to work. And that's how it started. So there's like, yeah, it sounds like a good idea, and we just decided what point we are going to meet, what point we are going to collaborate, what point they are going to come in. So there are a few things, like we had the staff focus group. So that we have to do it within NHS, because it's NHS staff. And then when we developed the questionnaire, I was like, okay, can you just look at the questionnaire? That you can check this. So we decided, pre-decided actually, that at what point we are going to do it, but every single thing was very, very transparent. So they were aware of how we are going, and the timelines and everything else. So what we did is, we took it as a quality improvement, service improvement program. So we took that quality improvement, that QI approach, and used that PDSA cycle. We took it as an action research project because we were evolving that idea while we are going through as well. So we are changing it. And we used it as a participatory open co-design method, where that means it was co-designed from the beginning. It was a collaborative effort. While we are developing, while we are implementing, while we are reviewing, at every stage, we had that collaboration. So this is what we did. We started with a staff focus group, which is basically, there are 3 areas we were exploring there. Is there a need? What do the staff feel that, do they think there is a need for this? What should be the content, and how should we provide it? What are the logistics? Do we have the resources to provide it? So based around that, we developed a questionnaire, and we did a 2 staff focus group. So the first one, just to get an initial idea, and then to refine it later. Then at the same time, parallelly, we were doing a service user questionnaire. So those people who are admitted to our stroke rehabilitation unit, their family and carers, we just gave it out, the questionnaire, just to identify exactly the same thing. Do you think there is something missing? Is there is a need? And if it is so, what is the need? What kind of question? What kind of topics that you would like us to cover? Who is the best person? Is it via Teams? Is it via face-to-face? Like, we asked all the practical questions, but at the same time, we obviously asked that, okay, do you feel there is a need? Because we thought that that's the best thing to ask them, actually, because we thought that, okay, we should support them, but we did not know what's the best way to support them. So we did that, and then obviously it was an action research project, so we triangulated the data. We come up with some themes from the staff survey. We came up with some themes from the service user questionnaire. Then we triangulated, saying that, okay, where are the themes matching? And then we developed the content. So the content was a 6 weeks program, which I'll talk about. And in the meantime, as I said, at every stage, Stroke Association and David, who is the service user, was involved, like developing the questionnaire, to analyzing the themes, like looking at that, okay, is it making sense? When we collate the themes to develop the contents of the program, we again just flag it up to them, saying that, okay, is that okay? Then we develop the slides even, and then we send it to them, saying that, okay, is it making sense? Because we wanted to keep it very layman terminology, because that was my challenge, actually, because when I asked the team to develop, the slides were like, okay, like the physios, OTs, and speech, they were like very passionate about their profession. They were like, okay, we need to provide that, we need to provide that. I was like, well, we can't provide everything. And the language that we are using, like, it's too much. And that is available in Stroke Association. There is a lot of leaflets and everything else. So as Avril was saying in the earlier session, we don't need to reinvent the wheel. So I was like, what is this program about? information is always available there. But what are the slides? The slides is about, so we said that the theme is about dealing with their emotional need to be heard, to be listened to, and to have their questions answered. And somebody just, that they are just thinking, because they think that, okay, in the busy NHS place, actually, everybody's running around. They feel guilty that we do not want to ask the staff because they're really, really busy. So we said, okay, we will give you the focus time. What do you want to discuss? And they was like, okay, somebody who just gives us the headlines of things, know a little bit about stroke prevention, a little bit about that. So, so we try to get that emotional need that we need to know a lot of things, but we need to know when we're coming out what to do and where to get support from. We need to have that reassurance that this is not the end, this is the beginning kind of thing. So we thought there is a lot of emotional need that is not met. By giving them a signposting and then giving them just a leaflet is actually not meeting that need. So that's why we said that, okay, this program is actually about their emotional need to be heard. So based on that, we obviously developed this. This kind of started around May time last year. And then we developed the content around, and because it was going through quite a lot of refinement because of the language, because of the slide, it needs to be simple, digestible, and we wanted to keep more of an informal chat. At the same time, we need some formal presentation as well. So it's a mixture of all those kind of things. So we piloted the program in November last year. For 6 weeks, just to see that if it is working. So it's again asking that, getting that feedback that is it working based on what you said. We developed this, but is it working? Do we need to change anything? And incorporate that feedback. So we paused for a month or so over Christmas. So while we gather their feedback and then say that, okay, right, okay, if they wanted to change a few things, we worked on that. And then we just started in last month, actually, we started to roll it out for a year now. So we are just having the second pilot now. And in the meantime, we're still gathering lots of information because we're still saying that it is not the finalized program because we want to keep it as much as service user focused so that we know that we are meeting that need. Yeah, that's our timeline, and this is how the program looks like. There were 6 sessions based on 6 topics. It was not a huge time commitment, actually. It was a 45-minute session, so 6 sessions of 45 minutes, just because we're doing it in our clinical time, and it is our responsibility. It is there in the NICE guideline that we need to provide this, but we need to have that specific time dedicated to carers. So it was a challenge. It is still a challenge in NHS. We all know that we get busy and everything else. So running it every week is always a challenge. But we piloted it to discuss about the challenge and came out with lots of lessons learned. So the program, as I said, it's 6 sessions. I don't know whether you can see that. So it is having a range of topics there, starting from the questions like, do I have a chance? Do my loved one have a chance of second stroke? If so, what can I do? So it's kind of that question, like stroke prevention kind of slant, to how can I help them with their emotions, to how can I help them to move around, how can I help them on a day-to-day task, to how do I cope with that emotion that I myself is actually drowning, because caregiving is a huge task. So their well-being as well, and where do we get the support if I want, like at this point I don't feel that I need support, but later on if I need, where do I get that support from? So it is, as you can see, it's a range of topics, but it's a lot of things to go through. And obviously we included discharge because that was the biggest thing. They always think that, okay, to understand what discharge means. Now I completely banned the word discharge because when we say discharge, they think that discharge from life, actually. They just think that, okay, everything ends there. So we try to say it's a transfer of care. So your care is still on, but we are just transferring their care from here to somebody else, whatever is suitable. And we wanted to put that in a positive slant to discharge. And I think that was the biggest thing, actually, that we did, because people's perception changed about discharge. So what else I wanted to say here? Oh, yeah. So we had a 45-minute session, which is usually 30 minutes of presentation or discussions or interaction, and then a Q&A. And we kept that Q&A as a very generic one rather than a patient-specific one, because they always have their own stories. And we said that, okay, this is a generic, it's a group session, so we need to maintain that confidentiality and everything else. And obviously, in that session, we gathered lots of feedback and satisfaction as well. And this is a slide I wanted to say that that's the one that people find it really, really helpful, because most of the time before coming to the session, they did not know why they're coming to the session, what is expected. And they're very, very anxious. When we say that, okay, before coming to the room, you just stick a paper, stick a post-it note, red, yellow, or green. How are you feeling? What is your knowledge? How satisfied you are with your knowledge about caring your stroke survivor, your loved one? And most of them were quite anxious, actually. There are very few who said that, okay, yeah, we do know a little bit about stroke. And then you can see that it changed drastically. Like, none of them were no. They at least found that even if they knew the knowledge, that gave them the confidence that, okay, yeah, I think I know now where to get more knowledge from, or where to get support from. So it all changed from red to either an amber or a green. From our point of view, that was really, really good, that, okay, yeah, we are making a difference. But the most important thing I would say, when we asked them, a lot of the carers say that, okay, that was the best task actually that we did, because that is a self-reflection, that we were really anxious going into those sessions, but when we came out, it gave us the self-confidence that, right, okay, now this is not the bad thing, this is not actually the end of it. So I think that was the best thing. And I would really like to reflect on what we gained as a staff group, actually, the MDT group. I saw that trust growing between the service, as I said, there is a big gap between service provider and service user, but this was the best thing that I found, that the staff, actually, they felt that now we know how to deal with carers. Now we know, previously, oh, there is a complaint coming, oh, the family is really, really demanding. Now the attitude is, the family is really, really stressed, I think I need to spend some time with them. So I think that was the biggest culture shift for me, actually, that the staff developing that understanding how important it is to support the carers at the same time. And this was the best exercise that they have gone through, and the feedback and everything else was really, really helpful. And the staff developed that trust, understanding. They find it that we need to be reassuring rather than just providing information, because most of the therapists try to provide some kind of information, but that having that reassurance hat was really, really helpful. And I think the other thing for me to reflect on is that we had a really good shared learning, actually. We learned quite a lot from their feedback. And I think there was a very big impact on the health literacy of the carers. They did not know, like, a lot of people do not know how stroke is. And sometimes, like, okay, I want my family member, I want my loved one to be walking out of the unit when you finish rehabilitation in 6 weeks. Now, it's the start of a journey. Now, stroke is life-changing. It is for life. They don't understand. They just think that, okay, you can fix it and then everything will be fine. They did not realize that this is the start of a new journey. Things have changed. And I think having that time and space to give them that literacy, that, okay, right, it's not to worry, there is hope, but at the same time, you need to accept reality as well. I think they find it really helpful, and I think it was really good for staff to feedback on that one as well. Now, I'm not going to bore you on this one, the lessons learned. There was lots of organizational challenges, like environment and technology. I think we all know that in NHS, finding a room is so difficult. And we definitely did not want to do it in the ward, because that is, like, that inflicts anxiety anyways. So it's like, whatever happens, we're not doing it in the physio gym, because that's the easy way to do it. I'd stick it in the physio gym or stick it in the day room somewhere, or, it's like, no, that's definitely no. And that was the feedback we get from them as well. So it's like, okay, we need to find a room. So we had loads of challenges of, having a room, having the computer working, we all know that working in NHS. So there was a lot of challenges there, but it was a lessons learned that we need to plan it, and this is what we did, planning ahead for the whole year. Few positive feedback, critical feedback that we get, that we need some clarity of some of the slides. We needed some data. Some people like the data, some people like videos, things like that. So we changed our program based on those kind of things. What else? Engagement and interaction. I think we thought that we need to incorporate more engagement and interaction before they come to the session. So we thought that the key worker who is working with the family, they need to introduce the idea that this is happening. Are you aware of this? So you need to go into that one. So those kind of, so how do we communicate? We started putting this in their patient folder that, okay, family education is happening. If you're not aware, this is what is happening. So I thought we learned a lot that, okay, how can we encourage that? We still have challenges, but yes, working on that. So the key messages from the whole experience of PPI here is early engagement. Start as early as possible. I think Abby has said that, like, we could not have done this without having that initial chat with Stroke Association Wales and David in the beginning and having the staff questionnaire, because before even doing the staff questionnaire and the service user questionnaire, we started having very informal chat, and Becky was really good in doing that, like just going and having a chat. Like, we're thinking of doing this. What do you think about it? Is it something that could be helpful, or something that would, and if we provide this, would you be willing to come? You know, those kind of initial dialogue, that just testing the water, because all we are doing is understanding the need of our population and providing our service which is tailored to them. It's there in the guidelines, but we all know in a day-to-day practice that's the most difficult thing. And this is why we need to ask them. And I think that's the key message I would like to give. Get that early engagement, ask them. Obviously, as I said, needs of the service users at the center, because we are there for them, not for our job. We need to provide a meaningful service. NHS is great, but we need to make it more meaningful. We also think that we need to think about our quality improvement skills. I think everybody should be doing this one, and this is why probably you are here, and we're doing that task afterwards, just so that you can brush up your skills. And there are lots of help available, actually, that NHS staff are not aware of. If you have an idea, please talk to people, because there is help out there, and you can get help to develop that. And QI is a big focus now with NHS. So we need to do that and refine your skills. Definitely measure and evaluate the value as often as you can, actually, on the way, because that helps you to reflect, okay, we didn't think about that. And having that third eye, actually, like somebody else checking that, okay, have you think about that, is always a good idea. And last but not the least, which I'm just repeating what Abby has said, involvement in each stage, actually. It's like, when we're thinking of collaboration, it is not only collaborating or co-designing, we're talking about engagement and involvement. The whole thing in the ladder, actually, you need to think about that how can we involve them? And that's where I'm going to stop. Do you have any questions about the project? Yes, we are completely aware that there is a bigger need, and we definitely, that is the feedback we are getting, but it's the resources, but we are definitely thinking how to expand it a little bit. But for the time being, if their relative is still in the stroke rehab unit, we are offering that, because it's going to be unmanageable just because we are a very small team. Do not have a lot of admin support at the moment, but we're hoping to just expand it in a reasonable way. Yes. So we try, if they have missed out a session, so let's say this week we are having week 6, so they missed out all 5 sessions, so they will probably be joining the next cycle, which is starting next week. So it might not be, they might start with week 6 and then start with week 1 and 2 and stuff like that. Some people probably do not stay there for 6 weeks, so they might miss out on the last one. So we give them this, we have got a folder with all the information in there. So if they miss out, we just give it out to them. So we do have those kind of provision, but we are aware that it's only for people who are staying in there. So, and we have got EST service, so we are just definitely thinking that some people might have gone directly to EST and not come to the stroke rehabilitation unit, but they still have the same need. So we're just trying to expand it, but we definitely need to think about the resources, because that's the biggest challenge in NHS. Anything else? Right, okay, yeah.
Have you considered trying to do it online as well, so that you could reach people at different times?
We thought about,
well suited for online,
yeah. We definitely thought about that, but the initial staff survey, the service user survey we did, most people said that, okay, we don't want it online, we want it face-to-face. And we definitely, as I said, it's all about that emotional need. So we thought they don't see somebody sitting and talking to them. They found value in, and I can completely agree with that one. So, but we are thinking that some people missing it out. So probably we'll just either offer a recorded version of that or invite them over Teams. But again, we just need to think technology and everything else, And in North Wales, I think that is another challenge with service users having access to IT. But no, that's definitely in our thinking bucket, actually, that we are thinking about it. Any other question? If not, we probably go to the table task actually. And then on your tables, I think you have got 2 tasks, and we will be coming and talking to you guys as well. So start thinking about any ideas you have got. It doesn't have to be a great idea, just a simple idea either you have got, and what are you thinking and how do you think that PPI should be involved and where and all those kind of things, and we'll come and talk to you. And the second half, you will be discussing one task. You can decide within your table that one idea probably you need to take up to the next level and just do an PDSA cycle, which looks like this, which is there on your table again, which is right like this. So what is your plan? What you're planning to do? How are you planning to evaluate it? And what is the next action plan? So if you start thinking about the first task, think about an idea by yourself, and then we'll come and chat to you. We'll probably have more discussions. And the main idea is to about having more discussions about PPI. Okay, over to you.
So if you haven't already, if you just want to start thinking on your table, if you've got one idea in particular to pick out and start filling out your flip charts just with the idea. Any challenges or questions will just at the end of the session be coming round table by table. So if you've got anything then that you might want to bring, whether it's a good idea you've had on your table or a challenge or something, we'll be going around the tables one by one. Just to point out as well, the post-it notes on your table. If there's anything the network can do to be supporting PPI, if you've got any big questions, any support needs, jot them down on the post-it notes and we'll be collecting those in at the end.
Can I get your attention, guys? Are you ready to feedback? We're just thinking about time now. So if I go around the tables, if we can just discuss your idea, if there are any plans for PPI, at what stage you are planning your PPI involvement, and if there are any challenges or questions. Okay. Shall I start with the table at the back there?
So we've gone with this, we've got, well, myself and Fiona here, we've got an orthotic vision service which we're currently in development with. And we discussed the idea that obviously we've starting the project early on, we actually had some patient involvement with a couple of patients in like a patient forum who were talking about areas that from their patient journey where vision services could have been helpful to them, which has been an incredible thing to listen to and learn from for how we maybe set up the service as a whole. Essentially, we've got 12 months worth of funding for this, and sort of development in the pathway is for that 12 months, but with a view of trying to collect a lot of data which will come from the patients themselves and different methods of that. There's certain barriers towards it as well, which obviously we've only got 12 months to get a lot of this data, so it's a lot of work in one scope, but trying to use the project very early on with patient involvement hopefully means we're setting something up that will be very useful, as well as gathering the data of patients as we go can hopefully prove the worthwhile of the service as well. So we've, I suppose, started fairly high up on the ladder. We thought in many ways we are almost sort of co-design, co-production, a lot of it, albeit I say only a small number of patients, but the idea is trying to continue with a lot of that in place.
Yeah, good luck with that.
Thank you.
Yeah, but that's a really great idea actually. And when you're, especially when you're setting up a new service, I think that's great. Yeah. Next table.
Our table had a few projects that were more coming towards the end, so we discussed more kind of shared issues. So there's a few things that cropped up. Let me have a look at the post-it notes. One, we kind of talked about the structure of focus groups and whether it be truly representative. You know, would we capture maybe the diverse groups that we want to capture in terms of actually coming and speaking in that kind of forum? We talked a lot about locations as well, about we can be quite restricted to NHS buildings and how we could go about accessing kind of other free venues that might be more helpful and more accessible for different patient groups. What else? What else have we missed? Location.
That's always the issues in NHS, isn't it? Just resources and having rooms. Yeah. Is there anything else?
And the only other thing is we talked a little bit about the way the funding comes around, and actually to get service users involved at that very early stage of when your idea's just kind of being planted is hard, because sometimes the funding comes along and you've got to act on it quite quickly, and sometimes you might have missed the boat on that early stage of it being really truly co-designed.
Abby, do you want to add anything to that challenge of funding?
I don't think I have the answers for you there. Just a note that as much as we can strive for that top, I think it's just about coming up the ladder, really. So if for whatever reasons, venue funding, we can't be at that co-production, it's just about how close can we get to it within what we can with the barriers. I'm open to if anybody else in the room has got any suggestions on that.
No, I think the only thing I was saying, we were talking a bit about finances, and I think the reality is in terms of funded PPI generally only happens as part of research grants and research studies or discrete projects where you can actually apply for money and you're doing a big program and blah, 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 and you ring fence your budget. I think the difficulty is probably the majority of people in the room, if you're a clinical team, it's thinking about how you do that within your existing resource, and therefore you might have to go a bit further down the production, down the ladder.
Yeah.
The reality is though doing something is better than doing nothing, and getting the hang of it and doing it, you might do it better second time round, you might get. So I think don't be put off and think, well, I'm not doing the gold standard, therefore I can't do it at all. Do what you can, even if that's looking at we were talking about friends and family feedback, which is imperfect, but even if that's your starting point for the finding out the issues, then start there, because that is feedback, and then you can perhaps move up that ladder. But yeah, it is really challenging, and the NHS is becoming more and more financially challenged. It's not easy, so do what you can.
I agree completely with that. Unless we go for a research funding and stuff like that, all this co-design, co-production usually doesn't get, because we're talking in that table, isn't it? Like just we get paid to do this, but they don't. So morally, we need to just get them involved in that one. But yeah, but do whatever you can. It's better than doing nothing, actually. Because as I said, the service is for them. So we just need to try to get them involved as much as possible and wherever possible, actually. But if you're thinking of a bigger project like co-production and stuff like that, maybe go for a more collaborative project, which might be a research project which is a funded project. That might be a better one, actually. Okay, this table here. Oh, the mic is cut off.
Right, so in regards to the projects, there's some good projects that everyone's doing. We've just decided on the discharge letter process, because what we were finding within the local community, the area where I work, the reading age, when you look at the literacy levels and different things, was a lot lower than where our actual discharge letters were pitched at, because a lot of services, when they do discharge letters, CC the patient, the GP and the consultant. So what we were finding is if we were getting a lot of re-referrals back when patients are going to the consultants or the GP to say, for example, oh, I'm having a problem with this, and not identifying that we had looked at that previous point. Also, it kind of creates a barrier for the patient in regards to whether they take accountability for going forward. So what I found was, on speaking to the patients, the carers and different things, and the actual health professionals involved, that if I was to develop a letter that was just basically a table, this is what you said was your problem or your identified issue, this is what we did, and providing that along to the patient alongside to the consultant, it give more freedom of information. Currently, so I got feedback, as I say, around the template that I actually did, including the patients and the team. From there, we moved on to studying that feedback, making minor changes, based on the literacy levels and things still, and layout and font sizes. And then it's actually going to governance now, just to check that it is okay to roll out, and then I'll pilot it with the actual CNRT patients before potentially, if it works, rolling out across the therapy teams.
That's a great example how you can do it in a clinical team, isn't it? When we are working at this small little things that makes a difference actually is actually PPI, and you don't need to go for a really large project with that one. As clinicians, we are very limited with resources and time and everything else, but that is making a clinical impact already. So, well done. Yeah. Moving on to that next table. Okay. Yeah.
We didn't, I don't think we actually had a project on the go, so we had an idea that came from a patient himself who's on the table, which was that they would have found it very helpful to have, a buddy service, and we then expanded that to a buddy service or peer support service for not just the patient but for the carers. But then we talked about how we might achieve that. We probably jumped straight into the barriers, but I'll move on and come back to them at the end, because we decided that was not a reason to not try. Very importantly, we should then ask the service users and their carers, family members, what they actually wanted it to look like. And the ideas were obviously to have focus groups, questionnaires, but importantly had to be broken down, to be quite specific, because some people at certain stages of the journey might not actually know what they wanted. And in particular, there's some examples were given that there was differences of views on what the family members and the patient might want. So we talked about involving people at different stages of their journey, because some people further down the road might have a different idea of what actually would have helped them earlier in their journey that they may not have been able to identify themselves at the start. Some of the barriers that we identified that were quite worrying around the table that professionals would have wanted a lot of help on were things like confidentiality, GDPR, how would you actually impart the information about the service users to the potential peer support workers and buddies, safeguarding issues, need for DBS checks and the like.
Thank you very much for sharing those ideas. Because of time, I think we're running out of time, so we'll just stop there. But thank you, and I hope that keeps you thinking, at least starting to think about PPI, and getting the most important people with knowledge and experience involved in this service designing and like improving our services. So hope that was helpful. Abby, you want to add anything?
No, just thanks all for coming today.
Thank you very much. And then just put your challenges, we can collect them.